the circulation of the new variants comes at a time when some states are now relaxing the rules and spring weather is on the way. Paul Kelly was just talking about some of the seasonal changes and some of the changes that he expects to see. We're looking at picnics and barbecues and baseball games and other outdoor gatherings really starting to scale up in the next few weeks and months. So what are the steps that you see need to be taken to respond to the variants, including those identified in the United Kingdom, South Africa, and Brazil, as the vaccine programs scale up? And does this change how we need to be thinking about this idea of herd immunity, given the new realities?
Thank you very much, Katherine. It's a great pleasure to be with you and with Dr. Kelly today. Yes, we've had a rather substantial difference in experience in the United States, the numbers that you just mentioned. I mean, we've had 525,000 deaths and about 28 million cases, which is really an extraordinary, historic, negative experience for us. One of the principles that we need to examine and adhere to, which becomes particularly problematic in the United States, less of a problem in Australia, is that when Australia shuts down, they shut down, and they really do get the cases like almost to nothing. We've never had that in the United States. If you can recall the history, which I painfully have lived through, is that in the very beginning, in the winter and early spring of 2020, what we had was a surge in the Northeast, which went up, and then it came down and never got to a good baseline. It was like 20,000 cases. Then we had the attempt to reopen the economy in the summer. Again, the surge went up, just the way Dr. Kelly had mentioned. When you try to open up, inevitably you're going to see some cases. However, the baseline was so high that magnified the impact of the surge. We went way up, we came down, and now the baseline was 40,000 instead of 20,000 per day. Then we had the massive surge up just this past winter and late fall. We were averaging an extraordinary 300,000 to 400,000 cases per day and 3,000 to 4,000 deaths per day. That's just a completely different galaxy than what Australia was experiencing. And now, as we're coming way down, we are reaching a point where we're beginning to, if not plateau, but the slope of the deflection is starting to maybe go down a little bit more slowly, which means we might plateau again at an unacceptably high level. Why do I go through all those details for you? Because a fundamental tenet of virology is that viruses don't mutate unless they replicate. And the more spread that you have in the community, the greater chance you're going to have of the initiation of and propagation of variants. And that's what we're seeing in the United States. We have the 117, which will be dominant by the end of March, according to the modelers. We have a low level of the 351, which is the South African one. Now we also have a New York isolate of 526, which is spreading rapidly in New York, and a California isolate, which is 427, 429. So we have variants literally in multiple parts of the country. The question we're seeing is that, luckily for us, the vaccines that are being distributed do very well against 117. We know from the experience in South Africa with J&J that it doesn't do as well, at least J&J vaccine, against moderate disease, but does very, very well against severe disease, including hospitalizations and deaths. We're trying to find out now what the impact of the homegrown variants, the California and the New York variant, is with regard to monoclonal antibodies and vaccines. So here is the challenge. Are we going to chase each variant in an almost whack-a-mole way, or are we going to try and get a vaccine that has a good degree of cross protection against several and get the level of virus so low that we don't really have an outbreak proportion? This may require coming back intermittently and boosting either against the prevalent wild type or against the prevalent variant. And in that regard, both strategies are being pursued in the United States. For example, Pfizer is planning on giving a boost of wild type because we know of the good cross protection, for example, against 117. We are working with Moderna to develop a South African isolate specific vaccine boost that might be able to protect against that. Of note, we found that in other experiments that individuals who were infected with the South African variant made a protective antibody in convalescent, not only against the variant, but against the wild type. So it's really quite interesting how there's that cross reactivity. Bottom line is we really cannot predict very accurately what's going to happen on a seasonal basis. But the best thing that we can do really is to get as much control over the existing replication and dynamics of the virus. Just want to close on one observation that I've made consistently over the years, over the months following Australia, something that we did not do as well as Australia. When Australia locked down, they really did. They got the level down very, very low. If you look at the monitoring of how well we locked down, we never really locked down completely. We had a terrible economic impact, but we never really locked down as well or as completely as Australia did. And I think a combination of the other things that Australia did correctly really led to the fact that they've done really quite well when you compare them to other countries in the world.
So when you were talking about the surges of the different cases, I was thinking about roller coasters, and then there was whack-a-mole, trying to go after the different variants. But really, it sounds like the push for vaccines and potentially boosters is something that really, being able to roll those out across the country very quickly is something that is a key area of focus. Paul Kelly, I want to turn back to you. As you mentioned, the vaccine rollout in Australia is underway with the Pfizer-BioNTech AstraZeneca products being rolled out now. There were some hiccups, I guess, in the process last week with Italy halting a shipment of the AstraZeneca vaccine. But as you've said, plans for domestic production are getting underway this month, if I'm not mistaken. So with so few COVID-19 cases historically and very few currently, how do you see the public really responding to the vaccine campaign? And I think you hinted at this earlier, but do you think people will be comfortable going back to restaurants and offices and other places after having really complied so completely with lockdowns and social distancing in a way, as Tony Fauci has said, we really didn't do as much in the United States? How do you see that?
Yeah, so the way that the Australian people have listened to the health advice has been, I think, quite extraordinary. In my whole career, I would say I've never been in that situation where our epidemiologists and public health officials have become rock stars in a way on national television every day, standing up with the heads of government, our equivalent of governors here, our state and territory premiers, and or the Prime Minister. But they've really listened, and they've taken on board all sorts of things I didn't think they would. So, for example, I like Dr. Fauci was not a great fan of masks at the beginning, and I didn't really, mainly because I didn't really believe the Australian people would use them or use them properly. But they have, and they've really embraced that. When we've asked for people to limit their macro or micro distancing, so keeping apart or not limiting numbers of people in places, they've really done it. In the past couple of months, we've had very swift and very rapid and complete lockdowns for a very short period, as Dr. Fauci mentioned, and again, people have complied with that. So now we're quite open. We're essentially completely non-immune, and so people are really they're really embracing the vaccine program. We had a bit of a hiccup there for a while about whether Pfizer was better than AstraZeneca, but I think the real world experience now from the UK in particular has shown that that's not an issue. So I think people are embracing one or other of the vaccines, so that's happening. And so, and I think in general, it's a program that will be very successful. In the first 2 weeks, we've got to 100,000 people for the first dose of the Pfizer vaccine, and the AstraZeneca vaccine, starting with supplies from overseas, is in the field now, and within the next couple of weeks, our locally production, locally produced vaccine will be available. So we'll carry on, and I think there will be a very, very successful program. The logistics here, as in the US, is difficult because of the size of the country, particularly with the Pfizer vaccine and the logistical challenges there. But we'll go with that. And I think, as Dr. Fauci mentioned, this is the first vaccine, but not the last vaccine that people will have, and people are understanding that need for a booster probably at some time. I think we'll return to the concept of vaccine nationalism, and you mentioned the issue with Italy last week. That hasn't changed our plans at all, but it does raise an issue that we need to think about, and I think it's one of your other questions, so I won't go into that at the moment. But how we think about global solutions for a global pandemic, and Dr. Fauci's touched on that already about the importance of the virus will continue to mutate and create variants if there is virus circulating and many people with that virus. So we all need to think about that concept of where, if there's virus anywhere, virus can be anywhere, can be everywhere rather, and so we should be working together on that.
Thank you. So, Tony Fauci, I want to just stay on this issue of vaccine demand for a second. After sort of a fitful start here, there's been a rapid scale up of vaccine distribution in the United States. Nearly 60 million people have received at least one dose, and now more than 2 million people per day are getting shots at pharmacies and health centers, large stadiums, convention centers with drive-up options. I mean, there are lots of options for people to get their vaccines. Now that there are 3 approved for emergency use, it seems likely that some of the supply challenges we saw back in December and January may wane, and that issue of demand may become more prominent. Polls show that more of the public is willing now to get vaccinated than back over the summer or early fall, but there's still a pretty big number in the wait and see category, kind of wanting to hold back. The America Rescue Plan has set aside around $1 billion for confidence building programs. I just wanted to ask what you see as sort of the best way to build vaccine confidence among a somewhat divided public, particularly with this threat of variants ongoing. And just thinking about some of what Paul Kelly was saying, in Australia, as people have kind of begun to think about how to emerge from these lockdowns, as you think about the recent CDC guidance, how do you convince people who've already been vaccinated that they still have to modify their behaviors?
Well, Katherine, there are a couple of questions in there. Let me try and unpack one or two that are important of what you said. Well, yes, there is a degree of vaccine hesitancy that's different among different subgroups of people. One, for example, in our minority population, understandable hesitancy due to the history of mistreatment on the part of the federal medical initiatives dating back to the infamous Tuskegee incident, even though literally of overwhelming percentage of the people who we're trying to address were never born yet at the time that Tuskegee occurred, but it's been passed down from generation to generation. So the first thing we need to do is to respect that hesitancy and not confront it, but say that we understand why you are hesitant. And we have now ethical constraints in place that would make something like that impossible to happen again. Having said that, to then address the concerns, that it go too fast, explain the speed did not compromise safety. It was merely a reflection of spectacular advances in the science of platform technology and immunogen design. Then to explain and articulate clearly by people who they trust in their community. That could be celebrities, that could be people who are relate very well to the community, that the decision to make this available because of its safety and efficacy was made not by the federal government as a political organization, not by the drug companies, but by independent data and safety monitoring boards and advisory committees. Once you get that through them, you will convince a considerable proportion of the people who are hesitant. And we're starting to see, I think, as you realize, Katherine, that as the days and weeks go by, the percentage of people who are now more confident grows literally every week. And I think what we're seeing is that the more people that get vaccinated, it will create a momentum of its own, particularly for the wait and see people, because they will wait and see. And then when you get 100 million, 150 million, 175 million people vaccinated, then you're going to have people say, well, it looks pretty good so far. Let me get vaccinated. So I think we're going to do that. Vaccination throughout the world, but in any individual country, and I'll speak only for the United States, is really the solution to the extraordinary stress that people are under right now. People do not want to tolerate anymore the restraints that we have now from a public health standpoint. And if vaccine gets them quickly to somewhat of a degree of normality, that is the big carrot when it talks about vaccines. People want to get back to normal. They do not want to stay constrained from the public health measures. So I think both of those things, an explanation of the objections that they have, addressing them in a reasonable way, respecting their hesitancy and explaining why they should not be hesitant, as well as showing them that vaccines are the pathway to normality, and everyone desperately wants to get back to normal.
So let's turn to global issues for a moment, and this issue of vaccine solidarity, or maybe COVID solidarity. Many people, as you've just said, Dr. Fauci, many people are saying if we're not all protected, then no one is protected. Australia and the United States, as we've discussed, have had very divergent domestic experiences with the pandemic, but they're longstanding partners on regional and global health and security issues, including through APEC and the Quad, the informal security forum involving Australia, India, Japan, and the US that may reportedly convene again soon. So both countries have also indicated support for COVAX, which is the vaccine pillar of the ACT Accelerator, which was set up last spring to mobilize global multi-sectoral support for COVID-19 diagnostics, therapeutics, and vaccines. Australia has committed funds to COVAX and has made plans to purchase, I think, additional vaccines and supplies from the facility to support countries in the Southeast Asia and Pacific region. And the United States has approved $4 billion to Gavi, the Vaccine Alliance, for procurement and distribution of COVID-19 vaccines to the 92 lower income countries that are part of the advanced market commitment. So I wanted to kind of end by asking each of you to reflect on what you see for the future of cooperation on regional and global health security between the United States and Australia, and how can the two countries work together and with other countries, throughout the world to prepare for future pandemics and health emergencies. So Paul Kelly, let me turn to you to start.
Yeah, thanks, Katherine. And you're quite right. Of course, Australia and the US have a long-standing relationship on many levels. In 2020, there was a ministerial agreement in relation to the Indo-Pacific region in particular, and that covers a wide-ranging cooperation, including training, laboratory support, epidemiology, development of drugs and vaccines, and so forth for our shared region in the Pacific, and also more broadly in the Indo-Pacific. So Australia is very much committed to exactly what you were mentioning, particularly in our region. So Pacific Island states are very much front and center for our support, not only in the vaccine vaccines themselves, but the actual end-to-end rollout of the vaccines, as well as strengthening of surveillance activities, quarantine and the like. So that's going to continue. We have supported the COVAX initiative, as you've mentioned, a very important component of that vaccine rollout in lower middle income countries. And so we'll continue to do that. And we very much welcome looking further and more closely with the US in what we can do in our region. As I said, we are a connected world, and if we ignore that, it's at not only at the peril of the lower and middle income countries that can't afford the sort of things that we can afford in terms of healthcare and public health interventions, but also ourselves, not only in the continued production of virus variants, but in terms of threats through incursions. So I think that's a really important component of our work. We're particularly looking at a concern with countries at our near north, in Papua New Guinea and Timor-Leste, where there are emerging outbreaks. And so we need to really consider those in particular. But we certainly look forward to working with the US on these matters into the future. And I'll finish just by saying that whilst we have throughout this pandemic, of course, been concentrating on COVID as a specific issue, everything we've tried to do here in terms of public health strengthening in Australia and elsewhere has had an eye on the larger prize. There's no point in planning only for this pandemic. We have to consider what the next pandemic is going to be like. And so those generic strengthening elements are really important.
Tony Fauci, what do you see as additional research or programmatic policy-oriented collaborations between the United States and Australia that can help prepare for future pandemics and health emergencies while learning from the COVID-19 pandemic experience?
Well, as Dr. Kelly has said, the United States and Australia have a long, long history. I've been director of the Institute for now almost 37 years, and I learned on day one that our strongest allies in research was the top 2 or 3. Australia was clearly one of them, and we feel very strongly that this being a global pandemic and requires a global response, our collaboration, well-established firm collaboration at both the public health and at the basic preclinical and clinical research with Australia is a very strategic partnership, because it will allow both of us together to be able to implement in the Pacific region, involving so many other countries that Australia deals with literally on a daily, weekly, and monthly basis. The alliance between the United States and Australia will help the United States to be value added to the activities that go on in public health in the Pacific region. So I just see a continuation, an amplification, and an increase in the strong strategic alliance at the basic research, clinical research, and public health level with our Australian colleagues. It has been going on for years. It's been very productive, and I hope it will continue to go on and even amplify.
Well, Tony Fauci and Paul Kelly, thank you both for taking the time to join this session today. And thank you to our audience for joining us as well this afternoon or this morning, early morning, I might add, for those of you joining from Australia. Thank you all. And I'd like to thank the staff at CSIS and the Indo-Pacific Center for Health Security for their support in organizing this meeting. Thank you very much.
Thank you.
Thanks, Katherine. Thanks, Tony.
Thanks, Paul. Thanks, Katherine.